All right. I'm sure this is very simple. That'll work? Okay. All right. Well, thank you so much to each of our panelists. Let's give them all another round of applause. So now we have 10 minutes to take questions from the committee. So happy to hear from, and we've got somebody with a microphone. Please go ahead.
Hi, I'm Bill Sage from the University of Texas. Thank you for great presentations. Let me put you on the spot. You're working with hundreds of young people in the upcoming generations, and particularly people from diverse backgrounds who face a number of personal challenges. What advice would you give Sue and Philip about their work in terms of defining competencies for nursing education and doing testing?
Wow. Yes, well, Philip, in the dirt, I think that's exactly the right thing when they're measuring competency. You know, especially when we're looking at diversity and we're working with specifically, we're in communities where our future nurses, and we believe will really understand that. I think that when they are going on to college education, I think those same understanding people's backgrounds when in their higher education and providing those supports is really important as well. I mean, our goal is that by the time they get into the nursing college programs, they have skill development. We've removed some of the barriers, but also recognizing that not every student is, focused on anatomy and physiology, and that needs to be some social supports and available on campus.
Angie?
Morning. So my name is Angie Mian from California, and my question is for Pam as well. I think your model is awesome, very awesome, and preparing underrepresented and high-risk students to prepare them into college. So my question is, what percentage of the students enter nursing as a career? And also, I saw that it was charter school. How is it funded?
We have a charter school, so we are a public education school. So we are funded through a funding formula, combination of the state and the local district. So that's how we're funded. We are collecting data. It's very difficult. We are collecting graduation, intended major. Many of our students, when we first started, many students were interested in nursing, but other healthcare. They're not all nurses, but they are healthcare. We do track them. Many of them start off nurses, but it's very competitive to get into a nursing program. We have created different pathways for our students. We look at this as a pathway, and our job is to make a very seamless pathway. So many of our students go on to the university, and we do have partnerships and MOUs and cohorts, and some of our students go on to the associate's degree that has an articulation agreement with a bachelor's degree. So I cannot tell you specifically because we have intended to be in nursing. They change their mind, students and adolescents, but we are looking forward to degree completion, and we're young. But the short-term results are promising, but we're in this for the long run. And we look forward to publishing that and collecting that. And but I do know anecdotally, because the kids are reaching out to us, that we have registered nurses out there.
Thank you.
Hi, my name is Regina Cunningham. I'm from the hospital of the University of Pennsylvania. Good morning, and thank you for those wonderful presentations. My question is actually directed at Philip. And Philip, I have a question regarding the practice analysis, which seems, such a fundamental component of how you're developing the items and thinking about the test. My questions are about, so I think probably be helpful to understand the methodology behind that a little bit better. Have you seen, as you do those every 3 years, have you started to see any increased focus on nursing work around social determinants of health? And are you looking for elements of that in a deliberate way? is my question.
So you're correct. We do them every 3 years. One of the issues that I thought was a problem, every 3 years seems to be like the more the better. The unfortunate thing about doing things every 3 years is you reset the baseline every 3 years and change is hidden. So I went back for the last 15 years to see what those changes have been. Now they have eventually showed up, but they're always, remember, practice has to change before it shows up, as opposed to, so there always seem to be a 3 year behind. My point is, what we have seen and was evident when we did that, and I think she's actually in the room, Nicole Williams, but helped us with this. She was an employee at the time and helped us with this, was that we added that cultural statement and spirituality because it showed up as actually change in practice. The other things, we see them, like community health has shown up as an actual change in practice. And so you're seeing that shift away to population health and that sort of thing that is actually showing up. So it does get there. The methodology obviously is that we do a couple things. One, that prior to the development of the practice analysis, we do two things: a complete lit review of practice that's going on now. Secondly, we do what we call nurse leader interviews. So these are leaders across the nation who are called, and we say, what do you see happening in nursing? What are the things? Those are added into the consideration of the survey form. We survey 12,000 entry-level nurses, meaning those with 12 months experience, and we do supplemental surveys both to nurse educators and employers to see what kind of correlations we get. I don't know if I've answered your question.
No, that's actually helpful. I was wondering about, the settings in which nurses practice. So, many new nurses do not practice in community settings. So
Correct.
I think that would, has a potential to be
Right.
biasing some of the information you're receiving. So, but that's actually very helpful. Thank you.
Yes.
Good morning. My name is Peter Burehouse. Thank you for the presentations. I have a quick one for Sue and a more in-depth one for Pam. Sue, I'm a faculty member, and we don't like having people come along and say, you need to do this, 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 and we're pretty good at resisting that. How do you get past, or are you finding resistance to your discussions about getting faculty to more in-depth, cover the social determinants?
So, one of the benefits of nursing, and one of the reasons I think the topic of the study is so important, is that there's so gosh darn many of us. We are everywhere, and so there's a lot of nursing schools. And I think AACN's work and the FIN1 work has gotten a lot of attention from schools that are interested and would like to go further or look at this, or we've had lots of people access the website and look for some of the tools we've been developing. So I think we've had a lot of interest, but there's an awful lot of nursing schools. I don't know that we've touched, even a significant percentage of them. And then I think it's working with faculty, and we're not resistant, we're charming, aren't we, Dr. Foreman? But I think it's working with faculty to really think about the measurement. I think people are into the concept. I think it's just that measurement. And that's really a challenge for us in academia across all the content we have, is how do we measure, to Phil's presentation, how do we measure the knowledge and skills we want them to have? And I think it's really helping faculty with the measurement. I don't think they'll resist the concepts. At least that's not been our experience.
Good, thanks. Pam, I'm going to need to set this up, but when I'm listening to your presentation, a couple of things are in my mind. One is, I was thinking about deaths of despair, and I think we're in the third year of declining life expectancy. And when you boil down all that work, the single largest predictor is failure to have a college education. And so I'm really tuned in to your work that's getting people into colleges. Those are terrific rates. So that's one part of this. And the next part of it is I'm thinking about work we've done to figure out, why do people go into nurses? And two elements are really key: what their parents advise, and at that point, teenagers listen to their parents. This is one of the areas they listen to them, is their advice on nursing, and it's pretty high. The second is an exposure to a nurse. Now, I'm assuming that many of the students in your world don't have a parent or parents to get that advice. How do you then steer people into nursing careers if they don't have the parental piece? How are you getting them to think about nursing?
Well, that's part of the innovation of the school is, and I think that's what makes us truly a nursing middle college, is the comprehensive approach to education. We work with the students and we work with the families. Many of our, as I had mentioned, our children graduate with workforce certificates. We see it as a pipeline. We extend our CNA programs and other programs to our parents. So we're putting them in the workforce. So it's not just about children. We bring parents' engagement, it's siblings and unemployed and underemployed. We see it as a comprehensive approach. So, and nursing still has a very high public image. So whether parents know about nursing or the profession, there has been some interaction, and nurses are still held in high regard. And I believe that is why, for 65 seats in 9th grade or vacancies, we have over 300 students and families interested in attending our school. And when I was talking about Phil with, about the NCLEX, we believe that our students are going to have a skill set for the future nurse unlike anyone. So just having these very sterile questions, I think our students are come with a phenomenal perspective, and we're really be prepared for the future of nursing. So, the exam questions and competency really needs to embrace a depth of what life is and what the patient's perspective, and I think that's where you need to measure competency. Thank you.
So I'm Marshall Chin from University of Chicago. It's a question for Sue. So social determinants of health is a phrase that a lot of people have adopted, and we've been perhaps too generous in what we allow people to call it. Probably I think about it in terms of like 3 different levels of social determinants of health. The ones the healthcare system tends to talk about are individual patient social needs. So identifying an individual social need, referring to a relevant community partner to address that individual social need. A second level is the structural determinants. So for example, if a social need is housing instability, working on housing is a more fundamental structural determinant, which virtually no health system is doing right now. And the third level is discussing about the underlying drivers of these social determinants. So things like structural racism, social privilege, which can be difficult discussions to have, especially faculty have not had training in how to facilitate these conversations. Which of these 3 levels do you think are appropriate then as competencies within the nursing curriculum, as well as should there be any type of variation across different types of nurses in terms of the expectations in any of these 3 different categories?
So of course, Marshall, you always ask great questions. So I'm a go big or go home person. I think all 3 of those levels are important at different levels of competence, at different levels of understanding. So, the structural racism issues, we may want different outcomes for those, and they may be more conceptual, more thinking, less kind of a skills-based. The first level you mentioned, I think we really want people to be able to do an assessment of some sort and follow through on it, no matter where they're at. Think about where their patients came from and think about where they're going afterwards. The middle level tends to be a little bit more in the public healthy realm and people that go into policy. So I might be softest on that it's concept in the back, that you're aware that it's important, but then that might be something that, depending on where a nurse chooses to go with his or her career, they pursue that more in depth. Public health people, that is their bread and butter, and they at least talk about it and try to do interventions in that way. So I think all 3 levels, but it might differ based on the program and based on where you're going. And I do think there's a leveling across nursing education. I'm not sure what it is yet, because that basic social determinants assessment, I think everybody with an RN license needs to be able to do that. That probably needs to be universal. It needs to be a part of the skill set. And we were talking yesterday in conversations about, I think nurses always knew how to do that. We didn't have a language for it, and the system didn't care about it, so we dropped it when we got. But I think we've always been taught to do that kind of holistic assessment. So I don't know that that one levels out. I think that one's part and parcel of a nursing role. But yes, I think we do need to look at levels of education, because you can't expect everybody to know everything in different levels of periods. So I think we do need to think seriously about what would it look like at the ADN level, at the bachelor's level, and then as nurses go on and specialize.
Thank you. I guess I'll start round two. This is for all of you. That is very helpful descriptive information to bring us up to speed. I didn't get a sense, though, in general, of like what you liked or didn't like about the status quo. And remember, the title of this is Future of Nursing 2020-2030. So I don't know if you can be a little more opinionated now in terms of what you like, and in particular, the things that you would change in terms of like where the status quo and the establishment is regarding education and social terms of health for nursing.
Where I want to go probably isn't, I don't get to control that because practice controls that. So what I would hope is that we can, one of the things I think that needs to happen, at least around the licensure exam, all right, is that that part of the wall between the licensure exam and education and the data that we collect needs to be broken down. So if we could provide data back to education programs, as I'm suggesting, in a much more finite way that provides information to educators that is useful around these issues, that we would subsequently see practice change. It would become solidified in a practice analysis. It's always a chicken and egg. Does the test drive practice, or right? So it's not supposed to, but so that's the one thing I would like to see change. We don't focus solely. Here's the problem I have with the discussion around measurement. If you want to measure social determinants, that is a construct all its own. NCLEX is a construct that's called nursing. So if you wanted to measure every construct in nursing, you could do that, but how many took that 2-day test? Yeah, I don't think we'll win that one, but if that were important, that's what we'd have to go back to. You'd have to have a section that said social determinants, and you'd have to measure the competencies. What I would like to see happen is, I agree that the education programs aren't experts in measurement. Why don't we help them build those items that would allow them to measure it better? That's what I would think.
So two things, I think, and I love the question because I'm sitting here thinking which ones, but so two things, I think. One is, I would like to see us move towards educating nurses to be more system disruptors, because we are at so many places in the system, and because I do think, major bias here, but it's mostly nurses, so I do think that we have had all along a lot of really great thoughts and ideas, and then we've kind of succumbed to the system. And I think a lot of what nursing practice has always been could have averted some of the issues we're having now if we had been more willing to be disruptors, more willing to be outspoken. And then my second piece, and for all the deans and directors, I apologize up front, but my second piece is, I really would like to see us do more continuing education. I think we have such robust, strong degree programs, but not everything has to be a degree. You get to a point where, you've pinnacled out. You are a DNP or you have a PhD, and we still need to change as the system changes and as we understand more about how to help people be healthier. We need more robust continuing ed that's intense, that's, I don't know, maybe required, and that really helps nurses develop skills to change as their career and as the system around them changes.
And the status quo, well, I believe myself and my colleagues were trying to change public education system to really focus on, we're doing something different. And if we're looking at building healthier communities, and we're looking at nurses taking on unique roles in the community. I cannot think of a more important role than being in a public school system. And really, it's not just about math and science. It's understanding the community and building those social supports which do not currently exist. Most schools have one school nurse. And we've built a model where majority of our professionals, and we have nurses who are guidance counselors, we have nurses who are inside the classroom, and they are providing the social supports. And once you address those social supports, then you can focus on math, anatomy, physiology, and you keep the cohort. So that's the status quo.
And as educators, I think it's important that we understand that there are also social determinants of learning, and as faculty, we need to role model that as we work with our students. So I think our time is up, and I think if you haven't learned anything in the last hour, you know that we're very serious about staying on time. So we're going to take a 10-minute break, and it really is 10 minutes. And when we return at 9:45, Dr. Elizabeth Aquino from DePaul University will guide us in a discussion around social determinants of health in nursing research and practice. Thank you.